This is part 2 of our review questions for growth and development. Question 6 gives us a concerned mother presenting with her 3-year-old son complaining of bedwetting at night, which is happening 2 to 3 times per week. She says that during the day, he is able to use the child's toilet and has very few accidents. He has no significant past medical history and is presently only on a multivitamin. His birth weight was 8 pounds 10 ounces, and presently he weighs 34 pounds. Physical exam reveals normal skin turgor and moist membranes. External genitalia is normal. Urinalysis is unremarkable. Which of the following is the best advice in this situation? A. Avoid beverages 4 hours before bed. B. It is normal for boys to have bedwetting episodes until age 5. C. Write a prescription for desmopressin. D. Use bedwetting alarms. Or E. Use a reward program. Alright, the answer to this question is B. It is normal for boys to have bedwetting episodes until age 5. So let's just look at this, this vignette here. So we have a 3-year-old that's having bedwetting episodes. This is something very common to see in pediatricians. So during the day, he doesn't really have accidents. It's okay. It's very common when you are dealing with a preschool-age child for there to be accidents. But he's having very few, so that's normal. He doesn't have any significant past medical history, so that's good. And he's not on any medication. He's on a multivitamin, so that's all good. His birth weight was 8 pounds 10 ounces. Right now he's 34 pounds. Remember that the child's weight should quadruple by 2.5 years of age, and that's happened. So 34 pounds, roughly quadrupled. Okay, it's not going to be perfect mathematically, but he is in that normal range. So when you look at the physical exam, you see that he's not dehydrated, he's got normal skin turgor, he's got moist mucous membranes, that's all normal. You always want to look at the external genitalia anytime there is anything that might be a urologic issue like bedwetting, and the external genitalia is normal. It's not necessary here, but for completion's sake, I included a urinalysis. It might be good to look at that just to see if there's something such as like diabetes insipidus that may lead to bedwetting. But urinalysis is unremarkable. And so the best advice in this situation is to reassure the mother. And so it is normal for boys to have bedwetting episodes until age 5. For girls, that's usually around age 4. Now, all of these other answer choices are going to be good answers to do if this continues past age 5. So you can do desmopressin, that's just ADH, that's going to reduce the urinary volume. Avoid beverages 4 hours before bed. Maybe you can avoid beverages before bed in this case, but most important is reassurance. That may not help the problem. Bedwetting alarms and reward programs, again, this is if the child is continuing their bedwetting episodes past age 5. So potty training is likely to be accomplished by age 4, but just remember that potty training is during the day. So if they're having bedwetting episodes, that doesn't mean that they're not potty trained. That's during the day. Bedwetting episodes, as mentioned, is normal in girls up to age 4 and in boys up to age 5. And remember that if potty training is unsuccessful, then a brief switch back to diapers is okay and you can try again later. Okay, question 7 gives us a 12-year-old girl presenting with her mother for her middle school physical examination. There are no complaints at this time. Her height is 5 feet and her weight is 158 pounds. She performs well in school and her interests include reading, watching American Idol, and participating in the middle school drama club. Her family history is significant for type 2 diabetes and her mother and hypertension in both parents. There is no known family history of heart disease. Which of the following is or are appropriate interventions at this time? A. Blood glucose screening for type 2 diabetes. B. Counsel mother regarding healthy eating habits. C. Trial of phentermine. D. Restricted calorie diet. E. Immunization review. F. Counsel patient regarding sexual activity and safety. G. Counsel patient regarding healthy eating habits. And H. Serum lipid panel. So choose all that apply here. Now, there are probably other things that you're going to be doing given that this is a middle school physical examination, but I'm just asking you to choose all that apply as far as these answer choices A through H. She'll probably need some immunizations here too. All right, the answers here are B, E, F, and G. So here we have a girl presenting for a routine examination, but she is overweight. Clearly she is overweight. She's 5 feet tall and 158 pounds. I didn't put the percentiles on here. On the test, you should be able to know what's obviously overweight, and this is obviously overweight. She's above the 97th percentile for weight. Her height is roughly normal, so she is overweight. And all you have to do is look at a child, look at an adult, you know if they're overweight. So she performs well in school. She's got some interests, which is good. She's performing well in school, which is good. A lot of times you have a child who's overweight, there may be depression there, and so you always want to do a quick screen at least. Since she's performing well in school, that's a good sign. And she's got some interests. She has friends, presumably, since she's in the middle school drama club. She likes to read. She likes to watch TV. But note that these are very sedentary interests. She doesn't have any interests like playing soccer or doing track and field or walking, stuff like that. So that may be contributing to the overweight. Her family history is significant for type 2 diabetes and her mother. You'd want to take a look at her mother since her mother is there. If mom is overweight and daughter is overweight, there's probably maybe a genetic component, but probably also an environmental component. That maybe mom is making unhealthy food every night or fried food. And very important that if parents are making unhealthy food, child's eating it, child's probably going to be overweight just like mom and dad. Also, there's hypertension in both parents. That's also a comorbidity of being overweight. There is no known family history of heart disease, so that's good, but it's really irrelevant to the fact that you have an overweight child and you need to do something about it. So looking at interventions, do we need to do a blood glucose screening for type 2 diabetes? No, not in a child. We don't have any symptoms of diabetes here. So she doesn't have any symptoms, she's just overweight. So at this point, we don't need to do type 2 diabetes. Down the road, when she's an adult, if she continues to be overweight, then you can consider doing a fasting blood glucose, but that's not necessary in an asymptomatic child. Counsel mother regarding healthy eating habits. Absolutely. Mom and dad are making food for the family. Okay, so you got a 12-year-old girl, she's probably not making her own food, so it's important to counsel the entire family. Immunization review. So I think I just said we're going to have to do some immunizations for this child, but that's always an important part of any time you do a well-child visit. You always want to look at their immunizations, and that's probably going to be mandatory since this is a middle school examination. You're probably going to have to fill out some forms too. Counsel patient regarding sexual activity and safety. You'll probably want to start that around 10 or 11 years of age. When a child is starting to hit puberty, that's when you want to counsel a child regarding sexual activity and safety, because even though this is a young girl, that doesn't mean that she may have 13 or 14-year-old friends and who are boys, and peer pressure is always an issue, and so it's good to make sure that you get on that early. So around when middle school starts, that's when you're really going to want to counsel regarding sexual activity and safety. Just remember the standard practices. Usually we like the patient to be out of the room so you can get honesty, but if the parent objects, then there's really nothing you can do. But usually the parents are pretty compliant with it. If the child wants the parent to stay in the room, then certainly that's fine too. Counsel patient regarding healthy eating habits. So remember the previous question back in section 1 is that we had a really young child, like 3 or 4 years old. In that case, you're not going to counsel the patient regarding healthy eating habits because they're not going to know at all what you're talking about. This girl, though, is 12 years old, so she may go to the mall with her friends, and there's a food court, and is she eating French fries and fried food and ice cream, or is she choosing healthier habits? 12 years old is certainly an appropriate time to counsel regarding healthy eating habits. Now, there are some inappropriate things that you really should not do in a 12-year-old. First of all, trial of phentermine. Phentermine is a diet drug. It is certainly appropriate in very overweight adults. You can do that after you try a trial of diet and exercise and it fails. Then phentermine may be an okay choice given that the patient is healthy. Typically, if we're going to try this, we want their BMI to be over 27.5 with a comorbidity or over 30. And like I said, you have to try diet and exercise. But we never give that to children. So that's obviously going to be out. Restricted calorie diet is generally recommended that rather than doing a restricted calorie diet for children, that you increase their exercise. So you definitely want to restrict excess calories. They should be getting what is recommended, but you don't want to restrict their calories down to like 1,200 to 1,400 a day like you might do in an overweight adult. So restricted calorie diet, generally, I would say always on the USMLE, not a good idea for children. And then a serum lipid panel is not going to be necessary in a child. Pretty much the only time we're doing serum lipid panels is if we have a known atherosclerosis or very much suspected atherosclerosis in the patient, or if there's something really weird out there like a zebra, like familial hypercholesterolemia or something of that nature. Typically, we don't do any kind of serum lipid panels as far as screening until a patient is about 21 years of age. Okay, so this is pretty much everything I told you. So the management for overweight child. So first of all, you want to do patient and family education, dietary advice, so meals based on fruits and veggies, lean meat like chicken or pork tenderloin, fish, poultry, those are desirable. Things like red meat, like steak and hamburger, try to keep that limited. Whole grains are better than refined wheat products like white bread. Drink more water. Sweetened beverages like soda or fruit juice should be considered a snack. It should be considered a food product, not something for quenching thirst. So if you're quenching thirst, you should be using water. You shouldn't be using something like pop or fruit juice. Gradual approach is recommended based on individual behavior, and you should set realistic expectations. You shouldn't expect this child to come back in 2 months and be slender and normal. Referral to a dietitian or nutritionist is always a good idea. You should make ample use of those professionals because they're going to be able to give very specialized information to the patient. Increase physical activity. That's really going to be at the center, besides making sure that they're having a healthy diet, that's really going to be at the center of this patient's therapy. So you're increasing physical activity. Remember the vignette here. You have a child who's appearing to not get a whole lot of exercise. And so that's something that we can fix. Now, obviously, there are patients who get way too much exercise. You can have anorexia like that, but that's not this patient. So the AAP recognizes or recommends that there should be no more than 2 hours of TV or computer activity per day. And then also be aware of low-cost or after-school recreational activities for children in the local area, things like after-school sports and so forth. Special populations. So when we have adolescents, you may consider the use of sibutramine or orlistat in adolescents or adults in conjunction with diet and exercise, but we want to avoid things like stimulants like phentermine. Bariatric surgery is only indicated if the patient is skeletally mature and has a BMI of more than 40. So these are very special populations. Typically, these patients are going to be the ones that are morbidly obese. And that's not this child. We want to start out with just very conservative therapy in this child. And these are all recommendations from the AAP or in peer-reviewed studies. I didn't include the links to these, but you can look it up. And then referral for any comorbidities if necessary. Question 8 gives us a 6-year-old and his mother presenting with skin lesions on the hands. The mother is also concerned because recently he has been having trouble concentrating in school and appears listless at home. She describes him as always having been a picky eater and mostly preferring white bread and jam, Kool-Aid, animal crackers, milk, and noodles. He dislikes meat. He has a past medical history of seizure disorder for which he takes levetiracetam and lamotrigine. On physical exam, you note white scaly patches on both hands. There is no family history of any chronic diseases. Labs reveal a microcytic anemia. Occult blood is negative. Which of the following is the most likely diagnosis? A, undernutrition, B, inflammatory bowel disease, C, celiac disease, D, vitamin B3 deficiency, or E, vitamin B6 deficiency. Okay. So the answer here is E, vitamin B6 deficiency. So we look at this vignette here. We have a patient with skin lesions. That's interesting. We also have an unusually picky diet. Anytime you have a child with a very picky diet and not on a multivitamin, parent is letting the child eat whatever they want and only what they want, that is a risk for vitamin or mineral deficiency. The child has specific dislikes like meat. That's always a problem. Now, not saying that vegetarian diets can't be healthy. They certainly can. But when you have a vegetarian diet, education is very important, and so is a multivitamin, because there are things that are much easier to get in meat than in vegetables, and vice versa. The patient has a past medical history of seizure disorder. And now that's interesting. That might be non-contributory to this, because there are children who have seizure disorder. But that's something to keep in mind. And when you look at the physical exam, you see these skin lesions. They're white scaly patches on both hands. And you also note that the child has a microcytic anemia. You should get a CBC anytime you have somebody who's tired, if they're pale. You should always get a CBC, look for anemia, and we see that this is a microcytic anemia. Low hemoglobin, low MCV. If you do a smear, it'll probably be hypochromic. So that suggests that there may be blood loss, or there might be something else going on. But you do note that the occult blood is negative. And so there's no blood loss going on in the GI tract. So that is going to get rid of inflammatory bowel disease. Celiac disease is a possibility. However, typically with celiac disease, you're going to have malabsorption of fat. And we don't see that this child is underweight. We also don't see that this child is having malabsorption of vitamins A, D, E, and K. And that's typically going to happen with celiac disease when there's malabsorption. With vitamin B3 deficiency, usually we're going to see other symptoms, and that's niacin deficiency, and those symptoms tend to be different. The answer here is vitamin B6 deficiency. What we're getting here is a child who's got skin lesions. You see that with vitamin B6 deficiency, and what's important here that you note is two things. The white scaly patches, that comes with vitamin B6 deficiency, this is pyridoxine deficiency, and then also the seizure disorder. You get seizures from having a low pyridoxine. And so those two things, as well as a microcytic anemia, because pyridoxine does play a role in the folate cycle, those all point towards B6 deficiency. So the pyridoxine, this is a coenzyme constituent in amino acid and glycogen metabolism. It also plays a role in the synthesis of heme and neurotransmitters. It's involved also in steroid action. Notably, it's involved in the metabolism of homocysteine to cysteine. This is all part of that folate B12 cycle. And so its deficiency is going to result in an elevated homocysteine level. Deficiency is associated with low intake, which we do see with this child based on that picky diet, malabsorption, dialysis, and some drugs. Now, remember that pyridoxine deficiency is associated with seizures. What do you give for seizures? Anti-epileptic drugs. And anti-epileptic drugs will be a risk factor for pyridoxine deficiency. So you can have a vicious cycle here, and that's indeed what we have. Keep that in mind. There's also an association with liver disease, SCD, CRF, and chronic inflammatory conditions. There are a unique class of inborn metabolic disorders known as the pyridoxine-dependent diseases or pyridoxine-dependent states, and those include pyridoxine-dependent seizures, pyridoxine-dependent anemia, and homocystinuria. Okay. So pyridoxine deficiency typically manifests as listlessness, irritability, skin lesions such as cheilosis, glossitis, and seborrheic dermatitis. That's what we have in this kid. That's those scaly, white, sort of crusty patches, and then oxalic acid stones. In the pyridoxine-dependent states, depending on the disorder, manifestations can include seizures, microcytic anemia, and homocystinuria. Remember, when you have a child with seizures, if it's not responsive to barbiturates or benzodiazepines, give an administration of pyridoxine. A lot of times when you have refractory seizures in children, pyridoxine deficiency may be behind it. Workup, you want to do a CBC. We did that with smear and iron studies, BMP with calcium magnesium levels, and then a vitamin B6 profile will be diagnostic. The management is going to be oral pyridoxine replacement, followed by adequate intake. You can do an IM replacement if they're having a seizure. Certainly can't do an oral replacement if they're having seizures. Consultation with dietitian, neurology, hematology as appropriate. In older patients, you want to assess vascular health. That's because of the homocystinuria being a possibility. Now remember that we always test for homocystinuria when we do a newborn screening, but if you go back 30, 40, 50 years, that patient may not have had a newborn screening, and so you want to look for vascular health, which can be a complication of homocystinuria, and then you'll follow up to monitor progress. Question 9 gives us a 2-year-old boy presenting with his parents for a well child exam. There are no complaints at this time. His height and weight are tracking in the 40th and 45th percentile respectively. He talks in basic sentences, enjoys chasing his dog, and is sociable and pleasant, though he prefers his mother. He prefers peanut butter sandwiches, milk, cut-up chicken, and rice. He dislikes fruit. On physical exam, you note petechiae on his arms and legs, mildly friable gums. His incisors and canines have erupted, but no molars appear present. CBC reveals a mild microcytic anemia. Which of the following is the most likely diagnosis in this patient? A, vitamin K deficiency, B, Nocturnal line purpura, C, ITP, D, scurvy, or E, rickets? All right, answer here is D, scurvy. So we know something's wrong because look at the answer choices we've got. We also see that the child has petechiae, and if I could have included, but I didn't want to give too much away. This is going to be parafollicular petechiae, which is very much associated with scurvy. So if you look at the petechiae, they're going to be surrounding the hair follicles, where the hair comes out. And also what we see is mildly friable gums. Say that 10 times fast. This is very characteristic of scurvy because here we have a bone coming out and the tissue is friable, and that's something you'll see a lot with scurvy. Incisors and canines have erupted, but you don't have any molars present. Typically, a child will start to erupt their molars around this age. And then when you look at the diet, you see peanut butter sandwiches, milk, chicken, and rice, but no fruit in the diet, no fruit juice, nothing with vitamin C, and so there is a deficiency. Typically in the United States, when you have a vitamin deficiency, it's going to be a child with either an unusual diet because the parents think that their kid should be vegan or their kid should be vegetarian, or you have a child who's very, very picky, and rather than the parents give the kid a multivitamin or tell a child they need to finish their fruits and vegetables before they leave the table, the parents just acquiesce to the child's likes and dislikes, and with that picky diet, they develop a deficiency. Now, we see other things. The child is otherwise normal, talking in basic sentences, chasing the dog, and then is sociable and pleasant. So that's all normal. There are some other things that you may see in scurvy. So you may see a scorbutic rosary, which looks a lot like a rachitic rosary. So that could confuse you between scurvy and rickets, but what you should look at with rickets is other things like bowing, genu varus, and then the diet will be different. So milk typically is fortified with vitamin D. So in that case, you're going to probably not have rickets since this child likes milk. Let's go on here. So scurvy, vitamin C deficiency manifestations are irritability, loss of appetite, frequent infections, leg tenderness, especially of the knees and ankles, scorbutic rosary, which is at the costochondral junctions, gum changes, parafollicular petechiae, and anemia. Diagnosis is typically going to be based on the history and physical. Work the patient up, you'll get a CBC with smear and iron studies. You'll also want to get a BMP with calcium magnesium levels, a radiograph of any affected bone that's there. We didn't see any in this child, and an investigation of any other suspected nutritional deficiency. Okay, question 10. So we have a 9-year-old girl presenting with her mother because she's gotten repeated notes from her teacher complaining of inattentiveness over the past 8 months. The teacher says she doesn't want to sit still. She plays with her pencils and crayons when she is supposed to work on her math problems and frequently interrupts at inappropriate times. Mom says she is otherwise a good child, but she doesn't make her do chores because she never finishes them and usually gets distracted by her toys or the TV. In the exam room, the girl is playing with the otoscope, trying to look into her mom's ear. On exam, you note a well-dressed girl, friendly but fidgety, appropriate mood and affect, no signs of delusions or hallucination, normal thought content. Physical exam is unremarkable. Which of the following is most likely the best management in this child? A. Methylphenidate, B. Sertraline, C. Magnesium pemoline, D. Special education, or E. Cognitive behavioral therapy. This is an extremely common vignette. And all of these things are very common in patients with this disorder, which you're going to need to know in order to choose the right treatment. All right, so our answer here is A, methylphenidate, commonly known as Ritalin. Now, there are other stimulants you can give this child, but there are no other appropriate stimulants on your answer choices here. So this is a child with ADHD. We know that this child has ADHD for several reasons. One, we have a child who's got difficulty paying attention in more than one location. So if you have a child who only has difficulty paying attention in school but not at home, or only difficulty paying attention at home but not in school, not ADHD. You have to have inattentiveness in more than one location, 2 or more. Other things that we see are inappropriate behavior, interrupting, fidgety. We see that the child doesn't want to sit still. What that probably is in kids with ADHD, what we believe is behind this is that there is a deficiency of dopamine. And so what is dopamine? It's that pleasure hormone. And so we do certain things. If you have ADHD, the child is going to do certain things that are pleasurable. So things like playing, things like fidgeting around, things not like sitting still or doing math problems. And so the reason that we give stimulants is because they increase dopamine. And by increasing dopamine, we're able to get the child to sit still and do their math problems because now they no longer have that drive to what we call it as self-stimulatory behavior. And so this is why we have that paradox, why stimulants actually appear to calm the child down, which you're not calming the child down. And indeed, one of the side effects of methylphenidate, Ritalin, any of the stimulants is that there can be sleep disturbances. What you are doing is getting rid of a hormonal imbalance. That's the theory. I don't think we've really proved that yet, but that's the theory, and it makes perfect sense. So you're not really calming the child down, you are fixing a hormonal imbalance. Now, some of these wrong answers include sertraline. This is Zoloft, and this is a medication that would be used for depression. So we have an appropriate mood and affect. The girl is well-dressed. She's friendly. Not really consistent with childhood depression. Magnesium pemoline. This used to be used for ADHD up until the mid-90s. This is a wrong answer. We do not use this drug anymore. Special education and cognitive behavioral therapy may be appropriate if you've gone through a few trials of different stimulants and you still have problems. So you could probably do methylphenidate in conjunction with cognitive behavioral therapy, but you would never do CBT alone. These stimulants like Ritalin, Dexedrine, Adderall, these are the centerpiece for ADHD therapy. So ADHD is characterized by inattentiveness, hyperactivity, or impulsivity that results in difficulty functioning in at least 2 settings, usually home and school. Symptoms must be present for at least 6 months. ADHD is a risk factor for substance abuse as an adolescent or an adult, so that's something to keep in mind as this child grows up. Differential will include age-appropriate behavior, so always keep that in mind. So make sure that the behaviors are not simply annoying to the teacher or the parent. This has to result in truly difficulty functioning. So the child is not achieving what we would expect for them academically. They're not doing their chores. Those are certainly not age-appropriate behavior. So we want to make sure that this is not simply a child that's perceived as annoying. So just because the child is running around, or they want to go outside, or they want to play with their toys more, that's not age inappropriate behavior. So always exclude that. Also, oppositional defiant disorder. So this can be concomitant with ADHD, but with oppositional defiant disorders, this is usually more of a defiancy towards figures of authority. So in this case, the child will be told things such as, you need to do your chores, and rather than going and playing with their toys, it'll be a no. There'll be argumentativeness. There may be serious behavioral problems in school, such as fighting or bullying. And so this goes above and beyond ADHD. This isn't simple inattentiveness. This is really bad behavior. And then any mood disorder should be considered, especially major depressive disorder. Possibly you may think of, I don't know, something like I wouldn't consider any personality disorders, because we wouldn't diagnose that in childhood. But you can consider possibly difficulty adapting to the school environment, especially if this is only happening in school and not at home. So other mood disorders can be considered as well. And then finally, the diagnosis for ADHD is clinical. There's really nothing we can do in the laboratory. So adjustment disorder would be one major, one differential for ADHD. So particularly if you have a child that's moved to a different school, you consider that.